Good morning, everyone. Thank you very much for joining us for the second day of our Genomic Forum 2021. I apologize for the little delay. We have had some technical difficulties. I would like once again to acknowledge that Genome BC offices are located on the traditional, ancestral, and unceded territory of the Coast Salish people, Squamish, Tsleil-Waututh, and Musqueam nations. I'm very excited about today, and we have a fantastic day ahead of us lined up with very distinguished national and international guests. And of course, we continue to talk a little bit more about the importance of genomic in this pandemic. We've seen yesterday how decoding the genome of SARS-CoV-2 is important to trace the transmission from one person to another, but also to trace the emergence of new changes within the virus and variants. And we now going to explore how these variants are important for the vaccine manufacturer and important also for public health measures, responsibility and considerations. And I am honored now to introduce the Vice Chair of our Board of Directors, Dr. Margaret Johnston. Peggy received her Bachelor's of Science from Carnegie Mellon University, which honored her in 2012 with a Distinguished Alumni Award and a PhD from Tufts University. After several years working in the lab, Peggy moved in 1986 to the US National Institute of Allergy and Infectious Diseases, directed by today distinguished keynote speaker, Dr. Anthony Fauci. During her 20 years at NIAID, she held positions overseeing research programs on HIV pathogenesis, drug discovery, and predominantly vaccine and other prevention approaches. Her career also included 3 years as a founding scientific director of the International AIDS Vaccine Initiative and 7 years as senior program officer at the Bill and Melinda Gates Foundation. Peggy is the recipient of numerous US government and non-government awards and author of over 90 publications and articles, including 7 co-authored with Dr. Fauci that were published in the New England Journal of Medicine, Science, and Science Translational Medicine. Fortunately for us, she married a Canadian and now resides in Vancouver and Salt Spring Island with her partner of 22 years. And so we are very privileged and fortunate to have her here with us. Over to you, Peggy.
Thank you, Federica. Dr. Anthony Fauci is the director of the National Institute of Allergy and Infectious Diseases, also known as NIAID. NIAID has approximately 1,000 employees and an annual budget of $6 billion. And it's the largest of the 27 institutes and centers at the U.S. National Institutes of Health. NIAID supports research extramurally and intramurally on HIV/AIDS, other infectious diseases, biodefense, transplantation, asthma, allergy, and other immunologic diseases. As director of NIAID, Dr. Fauci has served as a key advisor to 7 U.S. presidents. He was a principal architect of the President's Emergency Plan for AIDS Relief, otherwise known as PEPFAR, which has saved millions of lives globally. I was fortunate to have he's also I should also mention, his new job as a chief medical advisor to President Biden. I was fortunate in my last 11 years at NIAID to have a direct reporting relationship with Dr. Fauci. And I could spend this entire session listing the various prestigious national and international awards that he's received, but I prefer to share my personal view by echoing an op-ed columnist for the Washington Post, Michael Gerson, who, speaking about Tony, wrote the following, quote, "He is the best of public service, supremely knowledgeable, personally compassionate, completely non-political, tenacious in his pursuit of scientific advancement, and resolute in applying such knowledge to human betterment. He has no other ambition or agenda than the health of the country and world." Because of the dynamic nature of Dr. Fauci's calendar, he was unable to commit to be with us in person this week. So we agreed to pre-record a session, which we did last Friday. And as you'll see, even then, we got cut a couple minutes short because he got called elsewhere. So let's hear the conversation.
Tony, thank you for giving us this slice of your time. We really appreciate it. On behalf of Genome British Columbia, thank you. I want to start by asking you, have you heard of the Fauci effect?
Yes, I have.
Well,
hopefully that's a good thing. A lot of kids going to go into public health and medicine. That's good.
Which is maybe one of the silver linings here in this pandemic.
Yeah.
So prior to this recording, the audience here has been introduced to your day job, being director of NIAID. But I think the people would be interested in hearing about your career path and how you came to be the director of NIAID, and also what motivates you, what has motivated you, and what continues to motivate you to remain director of NIAID, particularly during these challenging times.
Well, Peggy, I got into what I was doing years ago because I chose the path of a physician, which my original thought was to be a practicing physician. I did not have any predetermined interest in fundamental basic research, but after my clinical training in internal medicine in New York City at Cornell, New York Hospital, I came to the NIH for a fellowship in a combined fellowship in infectious diseases and clinical immunology. And that was really the turning point, actually, in my one of the turning points in my career was to train for those 3 years and realized that I fell in love with research, particularly the interface between fundamental basic research and clinical applied research. And I went back to New York Hospital after my fellowship for another year of clinical training to round out my multiple years of clinical training. And then I came back and began a career at NIH in 1972. I came from my fellowship in 68. And in 72, I worked on the regulation of the human immune response. That was my theme. And I did that and had a very productive and enjoyable career studying diseases of aberrant immunological function, like autoimmunity, vasculitis. Then another life-changing event occurred in 1981, which is the durable life-changing event when I recognized the first few cases in the literature from the CDC of what would turn out to be HIV/AIDS, which at the time had no name of the disease and certainly no etiologic agent. And I began to study that intensively, again, at the interface between basic and clinical research. And then I decided, again, by just an opportunity that almost accidentally came in front of me, I really felt that we needed to put more emphasis on infectious diseases in general, certainly on HIV, and certainly on global health. And when the position of director of NIAID, the institute that I now direct, came open in 1984, even though I had trepidations about modifying my research and my other activities to become an even greater job, which had a degree of science administration, I made that decision, and it was the best decision of my life because it got me involved not only in having an impact and expanding the impact of HIV, because when I came in, our budget was like the budget of the Institute was $300 million, and the budget of HIV was about $15-20 million. Now, the budget of the Institute is $6 billion, and the budget of HIV, is about 10% of that. So that's pretty good. And that's what I've been doing ever since. And you got to know me when you were part of the team in the Division of AIDS, which I established, because one of the first things I did when I became director, there was not a lot of interest in the community of scientists in working on this new disease, this new mysterious disease. And even members of the staff here were not that interested in diverting their attention to that disease. And so I established a Division of AIDS, which has had a groundbreaking and transforming impact on the the conduct and the support of AIDS research, not only in the United States, but throughout the world.
And that's a good jumping off point for my first scientific question, which is the speed at which COVID vaccines came into being. and the particular role that genomics played in that, in getting us to this point, and also how it might get us into the future as well. So maybe you could review for us your view on how did we get there so fast, and what was the role genomics played?
Well, it was very interesting because genomic played a role in why it took such a long time, which is not took a long time, but why we had years of investment, and also why it went so quickly. I often get asked the question, and I've written a little editorial in Science a week and a half ago about the role of the investment of decades of basic biomedical research, particularly in the area of genomics being one of the most prominent areas. Most people say, you recognize the virus in January of 2020, and we have vaccine going into people's arms 11 months later. How did that happen? It's impossible. You should have years and years of investment to get a vaccine. And I point out to people that the work that we got to where we are right now with COVID-19 vaccines didn't start on January 20th. It started decades ahead, when we were able to sequence viruses. Instead of taking months and months, it takes overnight. And instead of looking at one single aspect of the virus, you can sequence quasi-species of viruses at a rapid speed. You could use structure-based vaccine design to design immunogens, and you could use new platform technologies to get the vaccine that you need into people as quickly as possible. So I think as the history of this is written, people are going to go back to the development of vaccines for COVID-19 as the classic example of how fundamental basic research in multiple areas, including genomics, led us to do something that a decade ago would have seemed completely impossible and out of the touch of reality, and now was done actually in a very smooth flow of activity from the virus itself up through the vaccine.
And I would add to that, if I may, having something in a bottle and getting ready to put into people is not, of course, the end game. NIAID invested a lot in infrastructure development, clinical trial site development in the developing world, training investigators, developing community relationships, developing collaborations. All of that, I think, coalesced to help the speed at which COVID vaccines came into being. Now, there are anti-vaxxers who aren't going to take a vaccine regardless, and there are those who are still concerned about safety because of the warp speed at which this came about. So could you just remind everyone of the various steps at which safety is evaluated and what we know about the safety of these vaccines?
Yeah, safety is paramount, without a doubt. It's paramount to what we do. And as you mentioned, Peggy, we put major investments in the clinical trial network dating back decades from HIV. And we utilize those networks to do the clinical trials that you're talking about. And so that is an absolutely critical part of what we do. But regard to safety, that's part of what we're talking about. So you start off with a phase 1 trial in the product to see if it has initial safety and whether or not it induces the kind of response that you would predict would be protected. Then we went on, just as an example of what we did with the COVID-19, we went on to a phase 2 and 3, again, to get the right dose, to get more safety data, and to confirm the immunogenicity. But then the actual trials that were done with Moderna was 30,000 people, with Pfizer was 44,000 people, and with J&J was another 40,000 people. All of those studies were done with a very strong look at the safety as well as the efficacy of the vaccines. And it turned out that they were remarkably effective, literally 94, 95% for the mRNAs, and really quite safe with no really red flag signal. One of the things that did happen that I think some people said, well, I'm a little bit concerned about safety, which actually is a manifestation of why and how we take safety so seriously. In the surveillance mechanisms that the CDC and the FDA have to look for even a rare adverse event, they picked up initially 6 serious adverse events with the J&J product in 7 million vaccinees. And that was less than 1 in a million. And they paused the studies to make sure there wasn't a lot more and to make sure that physicians knew how to treat this particular adverse event properly. And now we're gone back on track again with J&J. But what I do say is that, there were more than 150 million people who've received at least one dose. Only 8 million of those was J&J, which means 140 plus million doses of mRNA have been given with the same exquisitely sensitive surveillance system. Some even would say too sensitive surveillance system that allowed us to pick up the adverse events with J&J, and there were no red flags at all with regard to the mRNA. So I think that should convince people that safety is taken very, very seriously when it comes to vaccine trials and vaccine implementation.
And what can you tell us about the safety in children? Is that now being explored as we ramp down the ages at which these vaccines are administered?
Yes, actually it has. I mean, children and pregnant women, when you're dealing with vaccines, are what we call 2 vulnerable populations, which means that before you be doing anything on them, you really want to show that the product you're dealing with is both safe and effective in a normal adult population. Once you do, which we've actually done amply in the coronavirus vaccines, then you do safety trials and efficacy trials, which are not really clinical efficacy, but are bridge studies to show that in pregnant women, you can do a vaccine trial that's safe, but that induces the kind of response that is comparable to the response that gives efficacy in the larger efficacy trial among adults. Those studies have already started in pregnant women. We already have good immunogenicity and safety data and efficacy data in 12 to 15-year-olds, so that's adolescent high school kids. And both companies, Moderna and Pfizer, and even Novavax and J&J, are doing what's called age de-escalation studies in kids, which means you go from 12 to 9 years old, 9 to 6, 6 to 2, and then 6 months to 2 years. We project that by the end of 2021, the first quarter of 2022, we will have enough data to vaccinate children of any age. And right now, at any time now, we should be getting an extension of the EUA of Pfizer to vaccinate adolescents from 12 to 15.
That's really good news, particularly as communities try to open up schools and get kids back to school. Now, of course, the primary endpoints in the initial trials were protection from disease and hospitalization. And one of the questions that I think everyone who gets vaccinated wants to answer is, well, can I still get infected? And if I get infected, can I spread the virus to other people? So what's the status of research on those questions, Dr. Fauci?
So when the clinical trials ended, we did not know what the level of protection against infection, because as you mentioned correctly, Peggy, the primary endpoint was clinically recognizable disease. And we did extremely well with that. So now as we've gone further and followed people up and done other subsequent studies, it is clear that the vaccine clearly protects against any kind of infection. Not necessarily completely, but it does. And in those individuals who do get breakthrough infections that may not have any symptoms at all, the level of virus in the nasopharynx is at least 4 times lower than breakthrough infections of people who get infected without necessarily being vaccinated. So we're learning more and more that it is likely, highly improbable, that a vaccinated person, A, will get infected in the first place, and B, will transfer that infection to someone else. The reason we haven't made that determination yet, and why we still ask vaccinated people to wear masks, is not necessarily to protect them, which it does, particularly against variants, but to prevent them from spreading the infection to someone else.
And that, Dr. Fauci, is a good lead-in to the next series of questions, which is about the variants of concern. These isolates that we know evolved because of the mistakes that RNA viruses naturally make. So tell us about what we know about the variants of concern, how they've arisen, and what do we know about the effectiveness of the current vaccines against those variants?
Well, Peggy, this is a absolutely critical question that relates so closely to what the strategy for vaccination is in our own country, what the strategy for vaccination is in other countries throughout the world. So for the people who are listening, a variant is the result of usually more than one mutation of a particular wild type virus that changes it enough to have an impact. Mutations occur all the time, but a relatively small fraction of them actually have a physiological impact on the infection, either the infection rate, the infection severity, and or the relationship between vaccine-induced antibodies. But every once in a while, you get one that does. So let's talk about the ones we have. Currently, in the United States, the dominant variant is a B117, which originally was identified in the UK. It has an increase in its ability to spread, so it's more transmissible, and also somewhat of an increase in pathogenesis, namely the potential to make you sick. The vaccine that we have in the United States do very well against B117. There's a much more problematic variant in South Africa called B1351, which when you look at the antibodies that are induced by the vaccines we use, it diminishes their efficacy anywhere from 3 to 8 to 9 fold. But there's enough cushion of response that there's still some efficacy. And in fact, in the J&J study in Africa, it showed that although the 351 had a diminished efficacy, the vaccine had a diminished efficacy against 351, instead of being 90%, it was 50 to 60%, but it protected completely against severe disease, including hospitalization and death. Okay, so now there's another variant that's hanging around New York called 526. And that particular one right now is being studied. It has probably a 2 to 3 fold diminution in efficacy of the vaccines. Then there's a P1 in Brazil, which actually ravaged a bit of Brazil, and it's working its way up in South America. And again, the protection against the vaccine is diminished somewhat, but not nearly as much as the 351. Then there's one that we're focusing on very much right now in India, which is a 617. We don't know a lot about it. We're getting some conflicting reports where the initial report was that the Covaxin vaccine that the Indians are using works well against it, and yet we're seeing some reports that antibody induced by these vaccines are not protecting as well. I think we need to collect more data before we make any definitive statements about that. So those are a whole bunch of variants that we're dealing with.
Right. So as we get all this genetic information through sequencing, it's very important to understand where the variants are and how they're going. What does this portend in terms of the future of vaccines? Are we looking at potential of getting cocktails of vaccines in the future? Might there be the possibility of developing a pan-coronavirus vaccine that will protect against any coronavirus? What do you see for the future of vaccines and how this genomic information will influence those future vaccines?
Well, I think genomic information is telling us that we've got to go to the suggestion that you just mentioned. Because if we have to do a variant-specific boost every time we get a new worrisome variant, we're going to be chasing this like whack-a-mole. So I think what we really need to do is we really need to put a lot of effort, which we are, on first a pan-coronavirus 2 vaccine, and then a true pan-coronavirus vaccine for the entire family of coronaviruses. And one of the ways that allows us to determine the level of concern we should or should not have is to do very extensive genomic surveillance sequencing. You've got to sequence a substantial proportion of isolates to know if, as the virus is evolving in its pandemic spread, it isn't generating more mutants. Because if you don't look for them, you're not going to find them. And if you don't find them, you're not going to know what to do about them. So that's the reason why genomic surveillance is absolutely critical. And that's why the CDC, over the last several weeks to a month, has dramatically increased the percentage of isolates that they're actually sequencing. Because early on, they were sequencing really very few, comparably speaking.
Yeah, so can you briefly then tell us about the $1.7 billion program that was recently announced in the U.S. to detect and monitor the progression of virus variants? That's a substantial investment.
Yeah, it's a substantial investment, but it's going to be money well spent. It's a combination of a program that has a large component is in the CDC and a component at the NIH, which will be a joint venture to essentially get as many viruses sequenced as you possibly can and get a really good collaboration and coordination and transparency of what's out there. Because we started off really quite slow. When you compared us to other nations, we're really not doing as well. I think by the time we get well into this 1.9 or 1.2, whatever it is, $1 billion investment, we're going to be right where we want to be.
Right. Of course, and I'm going to want to shift into more public health related issues now. Of course, one of the key findings that I think would be very valuable is understanding what we refer to as the correlates of immune protection. The level, the type of immune response and the level of immune response at which someone is going to be protected. So what do we know about that? And also that kind of leads into a question about how to make the most of the doses we have. Many countries, including us here in Canada, we here in Canada, are delaying the second dose to get as many first doses in as many arms as possible. Yet we don't really have real-world information as to what the kind of decline of antibody responses are, how much is going to be enough to be protective. And you know, when I get my second dose 4 months from now, will I still have been protected during that time? Particularly people in my age group, which might not have as strong immune response as younger folks. So what can you tell us about the strategy and what's known about levels of immune responses that are required to maintain protection?
Right. Well, there are two ways to do that. What you do is you look at when the level of protection falls off. So in several of the studies that were done, there's no doubt that the second dose gives you a substantially higher degree of protection, both in true, real clinical protection, and we're getting data about that now, but also in the level of antibodies. So if you can establish what the correlate of immune protection is, you'll know when you need to boost somebody because you can measure a correlate rather than wait for a clinical outcome. So if you know that the level of antibody has to be at this level, and you have a level of antibody that's up here, you know that as long as it stays above that critical level where the correlate essentially falls off, then you can make a pretty good prediction of whether or not the level that you've induced is going to be protective. And that's the reason why we do a lot of immunological studies and we correlate the immunological studies with the clinical outcome.
So looking ahead now into the future, I think there are always lessons learned when we respond to pandemics. In your view, what, if anything, needs to change to better prepare the United States for future pandemics or to address this pandemic more effectively? Clearly, there's been variability in the various states to control the pandemics within that state. What would you change? What would you do differently? What would you do better?
Well, first of all, over the years in the United States, we've let our local public health systems languish. We've had so many people who have left the local public health system. And that really interfered greatly with our ability to identify, isolate, and contact trace. Also, we need to get a much more unified approach to a pandemic. You know, there's pandemic preparedness and pandemic responsiveness. We were felt to be, in the United States, the best prepared for a pandemic, and yet we did not fare very well. In fact, the United States, India, and Brazil were the three countries that were hit really very hard. One of the reasons that our response, I believe, was not as good because it was disparate. We're a big country, a great country. We have 50 states and additional territories, and we didn't do things in a unified, coordinated fashion. And some states, when they were supposed to be locking down, as it were, and obeying certain types of clinical guidelines for things like mask wearing, avoiding congregate settings, did not do it very well. And we saw multiple waves in this country, 3 major waves, and let's hope we're not going to see a 4th wave.
I understand you haven't taken a day off in quite some time. When do you foresee that happening, and what do you think you'll do?
That's a great question, Peggy. It's the truth. I haven't taken a day off in literally 15 months. I hope that when we start getting this under control, that it will be really permanent in the sense of getting the infection rate so low that it's no longer a threat. And when we get the overwhelming proportion of people vaccinated, not that we can take our eye off the ball, but that we could at least take a deep breath and just enjoy a little bit, like interacting with our children and our family, which we haven't been able to do. But the answer to that, Peggy, is something that you've worked on for the most of your career, and that's vaccines. Vaccines are going to get us out of this. We're doing an incredibly good job of implementing the vaccine program now. You know, we have more than 1/3 of the population is fully vaccinated, and more than half of the population, adult population, has received at least 1 dose. We need to keep that up, and if we do, there is light at the end of the tunnel.
Good. Well, my clock says I have 2 more minutes, so I'm going to squeeze in 1 more question.
Yeah, we have a national thing I got to do. I'm really sorry, Peggy.
Okay. Well, regards to thanks to Patty and Dave and everybody there, and regards to Doctors Auchincloss and Grady as well.
Will do. All right, thanks, Peggy. I appreciate it.
Thank you, Dr. Fauci.
Hello, everyone. I want to thank Peggy and Dr. Anthony Fauci for this fantastic conversation. It's been incredibly interesting. The points raised are extremely valuable. I've heard the importance of vaccines, which are safe and their efficacy also is safe. We've heard the importance of continuing to do extensive genomic surveillance, for continuing to track the changes that may make this vaccine in the future less efficient. And of course, we've heard about preparation and response to the vaccine for the future. But vaccine will get us out of here. And now we need to go smoothly into the next session, where we continue throughout the day to really dig into some of these details that have transpired from our conversation with Dr. Anthony Fauci. Thank you. Please go to the hub and view session for our next event. Thank you.